Welcome to this high-yield explainer. All right, if you're gearing up for your surgery resident exit exams, or you just really want to master endocrine surgery, you are in the exact right place. Today, we're going to break down the crucial presentation, diagnostic workup, and surgical management of thyroid carcinoma. We are distilling the gold standard surgical texts down to the absolute must-know facts. So let's dive right into this.
Here's our roadmap for today. We'll start with anatomy and nodule evaluation, move into papillary thyroid carcinoma, then follicular and hurdle cell, hit medullary thyroid carcinoma, and wrap it all up with anaplastic cancer and lymphoma.
Okay, Section 1, Anatomy and Nodule Evaluation. So, surgical safety literally relies on knowing the recurrent laryngeal nerve's vulnerability. As it enters the larynx at the cricothyroid joint, it's sitting right there at the level of Barry's ligament. You know, that condensation of pretracheal fascia. That is your absolute danger zone during a thyroidectomy. Furthermore, you really need to understand the lymphatic drainage. The subcapsular plexus drains principally straight down to the central compartment, known as level 6. That includes your pretracheal and paratracheal nodes. This is your primary zone of nodal clearance in a lot of thyroid malignancies.
Now, when a patient rolls into your clinic with a solitary thyroid nodule, the diagnostic pipeline is incredibly strict and systematic. Step 1, check the TSH level. Step 2, evaluate the gland visually with a high-res ultrasound. Ultrasound is your absolute workhorse here, letting us assess nodule margins, vascularity, and any microcalcifications. Step 3, if those ultrasound features are looking suspicious, you secure a tissue sample with a fine needle aspiration biopsy, or FNAB. For discrete swellings, FNAB is hands down the investigation of choice.
Sometimes, you might see a radionuclide scan used, especially if the patient happens to be hyperthyroid. The golden rule you need to remember here? Hot, functioning nodules are almost never cancer. We're talking a malignancy rate of less than 5%. However, cold nodules, the ones that trap less radioactivity than the surrounding gland, carry a 20% risk of malignancy. They absolutely demand an FNAB. Once you get that aspirate back, the Bethesda system kicks in to categorize the cytology and guide your surgical intervention.
Moving right along. Section 2, Papillary Thyroid Carcinoma.
You'll want to visually anchor this one in your mind. If you're looking at normal histology, you'll see these nice, normal, colloid-filled follicles lined with simple cuboidal epithelium. But contrast that with PTC, where you get these crowded, pale cells. Look for the famous orphan Annie-eyes, those optically clear nuclei. Those are the absolute classic hallmark of papillary carcinoma.
So what's the overall profile for PTC? Well, it's the big one. It makes up roughly 80% of all thyroid malignancies in iodine-sufficient areas. A huge red flag to look out for in the patient's history is childhood exposure to low-dose ionizing radiation. And unlike some other tumors, PTC is notorious for taking the lymphatic route, spreading lazily to local cervical nodes. Thankfully, because of those distinct nuclear features we just talked about, an FNAB is highly accurate for diagnosing it right there in the clinic.
For the boards, you absolutely must know how to stratify risk. We don't just treat all PTCs the same way, right? We use scoring systems like AGES, MASIS, AIMS, or the widely used TNM staging. Notice a recurring theme across all of these. Age. Age is a massive prognostic factor in differentiated thyroid cancer. In fact, in the 8th edition TNM staging, the magic number is 55. If your patient is under 55 and doesn't have distant metastases, boom, they are automatically stage 1, regardless of tumor size or lymph node status. Let's see how this builds out our surgical algorithms for PTC in the OR. If you've got a unifocal, low-risk tumor under 1 centimeter and completely clean nodes, a thyroid lobectomy is perfectly fine, and it spares the contralateral recurrent laryngeal nerve and parathyroids. But for tumors over 1 centimeter or anything with high-risk features, a total thyroidectomy is the gold standard. Why? 2 massive reasons. It lets you use radioactive iodine post-op to nuke any residual disease, and it makes tracking serum thyroglobulin an incredibly reliable tumor marker for catching recurrences.
All right, Section 3, Follicular and Hurdle Cell Carcinoma.
Okay, if you remember literally one thing from this explainer for your exit exam, let it be this high-yield rule. FNA absolutely cannot diagnose follicular carcinoma. An FNA just gives you loose cells. It can tell you, hey, there is a follicular neoplasm here, but it cannot tell the difference between a benign follicular adenoma and a malignant follicular carcinoma.
And why is that the case? Because diagnosing follicular carcinoma requires actually seeing the tissue architecture. Specifically, you have to find vascular or capsular invasion. Contrast this with PTC. While PTC spreads mostly through the lymphatics, follicular carcinoma is far more aggressive and spreads hematogenously, meaning right through the blood. This leads to distant metastases very frequently popping up in the bones and lungs.
Because your pre-op FNAB isn't definitive, your surgical game plan has to change. You start with a diagnostic thyroid lobectomy. You send that lobe down to pathology. If the pathologist finds capsular or vascular invasion on the final permanent section, bam, the diagnosis becomes follicular carcinoma. At that point, you're bringing the patient back to the OR for step 3, a completion total thyroidectomy, which then allows you to follow up with radioactive iodine treatment.
Next up, Section 4, medullary thyroid carcinoma.
Medullary thyroid cancer is just a completely different beast. It pops up from the neurocrest-derived parafollicular C cells. Because of this, it doesn't care at all about iodine, and it actually secretes its own primary tumor marker, calcitonin. Furthermore, it's heavily linked to familial RET proto-oncogene mutations, specifically what we see in the multiple endocrine neoplasia or MEN syndromes.
For these familial cases, we definitely do not wait around for cancer to develop. Prophylactic thyroidectomy timelines are incredibly strict. For patients with MEN2A mutations, specifically codon 634, surgery happens before age 5. For the highly aggressive MEN2B, surgery is actually recommended before age 1. But wait, here is the classic board trap. Before you ever think about taking a scalpel to an MEN patient's neck, you absolutely must rule out a pheochromocytoma. If they have one, that adrenal surgery has to happen first to prevent a lethal intraoperative hypertensive crisis. No exceptions.
Finally, Section 5, anaplastic cancer and lymphoma.
Anaplastic cancer. This is frankly one of the most aggressive malignancies in humans. It typically presents as a rapidly growing, rock-hard, fixed neck mass. These patients often come in already dealing with airway compromise and vocal cord paralysis. Radiologically, it's striking. You'll see marked heterogeneity, massive local invasions straight into the surrounding structures, and that classic central necrosis of a terrifyingly fast-growing disease.
Because it is just so highly invasive, surgical management is a real tightrope walk. An absolutely vital, evidence-based surgical rule to remember is that a tracheostomy should be avoided for as long as possible, unless there is true impending airway loss. Why? Because placing a trach often just introduces a non-healing, tumor-infiltrated wound. Instead, your real job as the surgeon is to determine if an R1 end-block resection, meaning you can actually remove all the gross disease, is even feasible. If it is, it's often followed immediately by adjuvant chemoradiation.
But pay close attention to this diagnostic divergence here. Say you've got a patient with a rapidly expanding neck mass. Is it anaplastic cancer or is it thyroid lymphoma? These are the great mimickers. Anaplastic is rapidly fatal and often highly palliative. Lymphoma, on the other hand, which typically pops up in the setting of chronic Hashimoto's thyroiditis, is miraculously responsive to CHOP chemotherapy. If you mistakenly do a radical operation on a lymphoma, you have done that patient a massive disservice. This is exactly why getting a core needle biopsy is absolutely critical to differentiate the two.
To wrap up this explainer, I want to leave you with a core philosophical and practical question for your career. When you are the one standing there holding the scalpel, facing down these vastly different pathologies, from a tiny, slow-growing papillary microcarcinoma to a totally devastating anaplastic tumor, how will you personally balance that aggressive drive for a complete oncologic cure against the permanent, life-altering risks to your patient's recurrent laryngeal nerves and parathyroid glands? It really is the ultimate surgeon's dilemma. Think deeply about it. Good luck on those exit exams and keep learning.